Hello! This week we're going back to the back. Didn't mean to make that little pun. We're going back to the back, and I thought that, because I've been talking to students about this week, we'll go low down in the back, and this is actually going to be a quite straightforward one, hopefully. I know, there's a huge amount of anatomy in the back, it's really complicated. But, have you heard of a lumbar puncture? Or have you heard of spinal tap? Not the band, but we're talking about the back, right? Epidural anaesthetic, spinal anaesthetic. Have you heard about all of those things? Right, well, what anatomy do you need to know about the back to be able to do any of those procedures safely and efficiently? Well, let's have a look. So we'll have a look at the bones of the back, although there's a whole other video about vertebrae, and we'll look at the spaces, and we'll look at where the spinal cord runs and how we might access the spinal cord. But we don't want to access the spinal cord itself. What we want to look at are the connective tissue structures covering it, the cerebrospinal fluid, the spaces, the spinal nerves coming out of it, and how might we access those spaces, because really we're talking about getting access to the CSF, the cerebrospinal fluid, and we use the lumbar region of the back for a particular reason, and we'll look at that. And what's the difference between an epidural anaesthetic and a lumbar spinal anaesthetic? What are you targeting? What different things are going to happen? We'll have a look and find out, shall we? This model always falls over, so look forward to that. So what's the purpose of any of these procedures? Why would you want a lumbar puncture? Why is it a lumbar puncture? Well, you might want to sample the CSF, the cerebrospinal fluid, somewhere around the central nervous system. Maybe you're looking for infectious agents like the bacterium causing meningitis. You've got a patient with meningitis, you want to find out you want to make a diagnosis. Maybe you want to put antibiotics in there, maybe you want to put chemotherapy in there, maybe you want to try and detect other cells or cancers in there, maybe you want to look to see if there's blood in the CSF, maybe you want to look for other infectious agents within the CSF. So you want to look inside the CSF. Now, where in the body is the safest place to access cerebrospinal fluid? I mean, sticking needles in the head is never good, and down here we've got spinal cord all the way, so if you're sticking needles in somebody's back, you do have a bit of a risk of putting it into the spinal cord. And how much space do you have there? Right, well, the spinal cord is covered in the same meningeal layers as the brain, right? The brain is covered by a thin covering of pia mater, and we see the spinal cord covered by a thin covering of spinal pia mater, which also follows the nerve rootlets out from the spinal cord. I've got other videos on these connective tissues and on the spinal cord and all that elsewhere. So you've got the pia mater, and then you have the arachnoid mater, which is the next layer out. But the next layer out from that is the dura mater. Have you got dura mater? Not up here, but we can see, I think this here, this is the thick dura mater. So dura mater is the thick or thicker, tougher connective tissue covering to the central nervous system. And the dura mater then, the arachnoid mater is lining the dura mater. So dura mater is fairly tough, arachnoid mater is fairly thin, and the spinal arachnoid mater is also very thin. And then you have the CSF, the cerebrospinal fluid, and then you have the pia mater covering the spinal cord, which means that the pressure of the CSF is actually pushing the arachnoid mater up against the dura mater, which means there isn't really a space between the dura mater and the arachnoid mater. There's kind of a potential space. You can see on here we've got a vertebral venous plexus. So again, these dural structures are also the same places where you're going to find much of the venous structures of the spinal cord, just as you do in the head with the brain. Dura mater, dural venous sinuses, right? And then in the arachnoid space, that's where you're going to find many of the arteries, just as we find arteries up in the subarachnoid space in the brain. Now, if the CSF is deep to the dura mater, deep to the arachnoid mater, then, and the pia mater is there, that means the spinal cord is not far away from the dura mater, which means you haven't got a very big space to sample your cerebrospinal fluid from, have you? And I don't know about you, it is doable, but I don't really like the idea of sticking a needle close to my spinal cord. And in fact, much of the bony structures of the vertebra make it very difficult to get a needle into these spaces anyway. Look at these thoracic vertebrae. These spinous processes are all overlapping. It's very shield-like. It's easier in the neck, but the neck again. Whereas down in the lumbar region, there are more holes, there are more spaces. And there's also a little bit of development in embryology which can help us out here. So in the fetus, up until about the end of the 3rd month, the vertebral column is the same length as the spinal cord. So the spinal cord reaches all the way down to the bottom of the sacrum and the coccyx, or as it is at that point. But as we continue to grow within the uterus, our vertebral column grows faster than our spinal cord, right? Which means that by birth, where are we? There's L5, L4, L3, L2, L1. Oh my God, I'm struggling to count backwards. So that means that by birth, a newborn child, their spinal cord will only reach about as far as the body of the L3 vertebra. And in you and me, assuming you're an adult, are you a newborn child or are you? Okay. As we continue growing into adulthood, again, the spinal cord doesn't grow as fast as the vertebral column does. So in adults, the spinal cord ends at about the level of about the L2 vertebra around here somewhere. So the spinal cord only goes about this far. So what's down here then? What's down here in this space? In this model, we've got a little tube in there which shows the spinal cord, or where the spinal cord would be within the vertebral canal, but this is just a model. So from 5, 4, 3, 2, 1. Okay, so from about here then, the spinal cord ends, and we've got spinal nerves coming out of the spinal cord at each of these spinal levels, right? But in us, because the spinal cord is kind of being pulled up the vertebral canal, the lower spinal nerves run down the vertebral canal and then run out of the vertebral column at each level, which means that in the vertebral canal here, inferior to the L2 vertebra, we don't have a solid spinal cord, we have the cauda equina. So the cauda equina, literally horse's tail, it's a load of spinal nerves running down and then running out again. So the spinal cord runs down through the vertebral canal, and about the L2 level it ends, it's kind of pointed, and this is the conus medullaris, that's like the last part of the spinal cord. And that spinal cord, or that conus medullaris, there's like a filament, a string, running from there down the rest of the vertebral canal, down to the coccyx, and that's the filum terminale. It's kind of, like anchoring it in place, right? Holding it down, it's like a guy rope. And we have the filum terminale internus and externus, depending upon where it is in relation to the structures I'm going to talk about next. The cauda equina then is represented here in pipe cleaners, pairs of colours here. So the cauda equina then are these spinal nerves running down the vertebral column, and then the spinal nerves run out like they do everywhere else from the vertebral column, right? So this gives you an advantage. This gives you one advantage to start with, right? So here's a model with a little bit more detail. So L5, L4, L3, L2, L1. So these are lumbar vertebrae and the sacrum, and the coccyx, and then we can see some of the spinal cord, spinal nerves and what have you. Now, while the spinal cord ends about here, the dura mater covering the spinal cord continues down within the vertebral canal, covering the cauda equina, and that sac of dura mater continues down to about the level of the S2 bone. The sacral bones have all fused, right, but down to about that S2 level, which means that and this is what you can see cut away here, you have this lumbar cistern. So a cistern, like a big space, right? Like a cistern on a toilet, like space filled with fluid. So this is the lumbar cistern down here. So from about L2 down to S2, you've got this lovely big dural space, the lumbar cistern, filled with CSF and filled with spinal nerves running through it. And that CSF then is going to be in the subarachnoid space. So it's definitely going to be subdural, it's subarachnoid. Now we also have what we call the dural sac, the spinal dural sac, and that extends all the way from, remember the foramen magnum, the big hole in the base of the skull? So that descends all the way down the spinal cord, and this is kind of continuous with that. And then that filum terminale externus anchors this lumbar cistern, this dura mater of the lumbar system down to the coccyx down here. So if you wanted to take a lumbar puncture, a spinal tap, to sample someone's cerebrospinal fluid, or maybe remove a bit to produce a bit of pressure or whatever, the stuff we talked about earlier, this would be quite a good place to do it, because for one, you've got a nice big cistern with CSF in it, but for two, you've got the cauda equina. Now if you stick a needle in here, and if you're not terribly careful with your needle, instead of the needle pushing into the spinal cord, which would do higher up and would do damage, you won't be able to push it into these spinal nerves. It's very unlikely. They'll just move out of the way, right? Because then they're in this nice fluid-filled space where everything's well lubricated, right? So there's a bit of safety built in there. You've got a bigger space anyway, filled with CSF. You've got a bit of safety because there's no spinal cord there. Now the other thing is that, as we talked about the different bones of the vertebral column, down in the lumbar region, there's quite a reasonable space to access the vertebral canal from the posterior aspect. You can't go from anywhere else, right, because this is all covered in skin. This is what we see here, right? The vertebral column is actually quite deep. It's covered in muscle and it's covered in skin. So, if you want to do your lumbar puncture, then you would ask your patient to flex their back and flex their hips, so curl up, right? So flex the hips, curl up and curl over. And that might be easier to do if they're led down on their side, or if they're heavily pregnant. You wouldn't be doing a lumbar tap on a heavily pregnant woman, but we might be getting access in this space for another reason. You might ask them to sit up and bend over. That might be easier. So whatever's easiest for the patient. But by doing that, if we consider we're most likely to go in between the L3 and L4 vertebrae, or L4 and L5, but let's take L4 and L3 and L4. These are the spinous processes here, right? Now, if you ask them to flex and bend over, you've got a little bit of movement there, and that gap between the two vertebrae opens up. So you've got a little more room to work in, which is always good. Now the other thing to consider is that you can palpate these, right? On most people, they're fairly superficial. These lumbar vertebrae. You can feel the spinous processes. You can start your way down and count your way up. But if you're going to put a needle through there, you're still going to have a number of structures to go through. So what are we going to have to put a needle through? Well, of course, you've got all that deep muscle of the back. But needles go through muscles, okay? We might want some local anaesthetic there. But what about ligaments then? 'Cause we've got loads of ligaments in the back, haven't we? Well, we've got ligamentum, we've got the supraspinous ligaments running over the tops of the spinous processes. We have the interspinous ligaments running between the spinous processes, and of course you've got the spinous processes as well. So you won't want to go at this directly in the midline, because you're going to have a lot to get through. That's not ideal. But these parts here, these are the laminae of the vertebra. There is ligamentum flavum, which is a yellowish ligament because it's got quite a bit of elastic material in there. So it's quite stretchy, which lets you do this. So it gets called the yellow ligament as well, I think. So ligamentum flavum, if you put your needle in from a slightly lateral between the two laminae of adjacent vertebrae, between L3 and L4, you're going to have to put your needle through ligamentum flavum. Now this being a ligament, this is going to give more resistance to your needles. This is going to be a bit of an effort to push through, but once you get to the other side, you're into the vertebral canal. There aren't any other ligaments to go through, so that's pretty tidy. And then the needle will get pushed through the dura mater. So then once it pushes through the dura mater and gets into the lumbar system, there's usually kind of a little bit of a pop, a lessening of resistance So this is a very gentle, gradual technique, and it pops into that space, and then you can access the cerebrospinal fluid and do whatever you want to it. So that's why you do it in the lumbar region, because there's more space between the bones, because you can make more space by getting the patient to flex, because you've got the lumbar cistern there, and because you've got the cauda equina there, which makes it a little bit safer. But there are other reasons we access this space as well, right? So the other reasons you might want to access these spaces are for pain relief. Epidural is commonly associated with childbirth. So what's the difference between spinal anaesthetic and an epidural anaesthetic then? Well, epidural means upon the dura, outside the dura, would mean the same as extradural, right? So there's a clue in the name. Now, if you were to give a spinal anaesthetic, you would be doing the same thing we were talking about just now. You would access the lumbar cistern, so you'd access the cerebrospinal fluid space, and you'd apply your anaesthetic to the lumbar cistern, put it into the CSF. So what will that do? Well, that's going to completely anaesthetise all of the nerves running through that space. So that's going to completely anaesthetise the patient approximately from the waist down. That's complete block. Well, that's the aim of that, is to give a complete block. So that's a spinal anaesthetic, and that would be, into the CSF. That would be within the subarachnoid space. So what's an epidural then? With an epidural, you would usually go a little bit lower, and if this is the dura mater here, you would try to access, so often it gets called a caudal, tail, a caudal epidural. So you try to go nice and low, and this one gets used in childbirth. This is quite popular in childbirth because you apply the anaesthetic outside the dura mater, so to these sacral nerves as they're leaving the sacrum. So really you're just anaesthetising the roots of spinal nerves S2, S3 and S4. Now what regions of the body do those innervate? Well, most famously would be the pudendal nerve, hopefully you thought pudendal nerve when I said S2, S3, S4. The pudendal nerve is the major nerve for the external genitalia, sensory nerve from the external genitalia and stuff like that. But you're also innervating many of the, you're also anaesthetising many of the other nerves, carrying sensory innervation from the viscera of the pelvis. So the visceral afferents, those sensory nerves from the viscera of the pelvis, they follow parasympathetic. They go back into the spinal cord about levels S2, S3, S4. So these spinal nerves you're anaesthetising should hit the visceral afferents from organs within the pelvis, which means that the patient's pain from the uterus and from the birth canal and from the perineum and all of those regions will have been blocked, will have been deadened by this epidural anaesthetic. I think with this one the anaesthetic leaks away much more quickly, so you tend to leave a what do you call it, a cannula, cannula in there, so you can keep applying the anaesthetic and topping up. Of course, childbirth is quite a long process as well. Now, actually, talking about childbirth, the uterus, right, the upper part of the uterus is above the pelvic pain line, which means the visceral afferents, the sensory nerves from the upper part of the uterus, will pass back to the spinal cord at lower thoracic and upper lumbar level. So those won't have been blocked, which means that mum may well still have some sensation of contractions, and still feel very much involved in the birth process. Whereas a spinal anaesthetic is just going to completely deaden everything. It's the sort of thing you'd use in a caesarean section. But an epidural means that mum is still very much involved in the birth, but the pain is taken away. It does tend to prolong labour, as I understand it. I think mum can still push to an extent, because upper uterus and also other muscles and what have you. So that's the difference between an epidural and a spinal anaesthetic. Of course, with a spinal anaesthetic, you're not going to be ambulatory afterwards because your lower limbs are being blocked as well. Whereas with an epidural anaesthetic, if you're only anaesthetising spinal nerves S2, S3 and S4, there's going to be lesser effects on the lower limbs. Don't go driving afterwards, but you will be able to move yourself around in bed and that sort of thing. You know what I mean? The other thing is, of course, if you're puncturing a hole in the dura mater, I think one of the most remembered or thought about side effects of a lumbar puncture or a spinal anaesthetic is that some of the CSF can leak from the dura mater, which gives a bit of a headache later. But the prevalence of that isn't terribly high. But it's, it's as side effects go, it's a fairly common side effect. So with a spinal anaesthetic, you can have side effects like a headache. With an epidural anaesthetic, you won't get that because you're not puncturing the dura mater. The anaesthetic in an epidural is outside the dura mater. We can see on this model here, look, you can see these are the cauda equina here. Spinal cord, spinal nerves. And then as we descend, it becomes a cauda equina. And look, here's the cut edge of the dura mater, continues all the way down here. Oh look, that's S1, S2, that's what I said, S2. So the dura mater continues down here. So this then is the lumbar cistern, this space here, L5, L4, L3, L2. Yeah, there's the lumbar cistern there and the cauda equina within it. See, I told you that was pretty straightforward. For the back, that's not bad, is it? So remember, the spinal cord only goes down as far as about the L2 lumbar vertebra in adults. Remember that the spinal cord is covered in the 3 layers of connective tissue that the brain is, pia mater, arachnoid mater and dura mater. Remember that the CSF is in the subarachnoid space. Remember that the lumbar cistern surrounds the cauda equina, those spinal nerves descending down through the vertebral canal. And that's about it, really, isn't it? And also, don't forget the difference between epidural and subarachnoid and that sort of thing. The same terms we use in the head we can apply to the brain. If you want to see more about the muscles of the back, there's a video about that. If you want to see more about the bones of the back, there's a video about that. So this collection of things is growing. So we're looking at the back in some detail. Oh, it's one of those things I haven't looked at in ages, and students were talking about it this week. And yeah, I thought that's a really clinical bit of anatomy. Let's delve into it. All right, good. Okay, see you guys next week.